So we are live now. We are streaming live now. So I'll start the session. Good evening, everyone, and I thank you all for joining us today. And with this, I warmly welcome you all to today's TRAZER Time webinar, which is an initiative about the knowledge update by ARUSH, which is a division of Corona Remedies. And the topic for today's discussion is what's new. What's new in the 6th edition of WHO Manual for Human Semen Analysis. And for today's TRAZER Time session, we have with us Dr. Padmini Prasad and also Dr. Rahul Reddy, who are the well-known persons from the medical fraternity. So with this, it is my immense pleasure to introduce Dr. Padmini Prasad, who is the first qualified woman sexologist from Karnataka, and she is the medical director from Ramamani Nursing and Maternity Home, Institute of Sexual Medicine from Bangalore, and she is the president of Bangalore Society of Obstetrics and Gynecology, and she is the chairperson for sexual medicine and STD community. And there is lot to talk about, madam. And Madam has won the Golden Lamp Award, Silver Lamp Award, and she's also the author of 11 books on sexual and reproductive health. And she has conducted various awareness programs on the sexual and reproductive health. So welcome, Madam. Thank you for accepting the invitation and being a part of this TRAZER Time webinar on what's new, the WHO Manual for Semen Analysis. So over to you, ma'am. Please do continue. Ma'am, you're muted.
Ellarigu namaskara, namaste to you all. A very good evening to you all. At the outset, I would like to thank Corona Remedies for making me a part of this beautiful program, a knowledge sharing program where we have to, all gynecologists must know what is new, what is latest, and what to know about, because day in and day out, the gynecologists will be handling the cases of infertility. And everyone knows that, and it's everyone's knowledge that male is responsible for at least 50% of cases and 20% exclusively, and another 30% a contributing factor. We all know how to ask for a semen analysis, but so many times we are in a dilemma as far as the interpretation is concerned. And semen analysis is the cornerstone of the male infertility and fertility evaluation. And we have this WHO guidelines, which provides the basis for all the standardization and reference values all over the world, right from the first manual, which started in 1980, up to today, after 5 editions, and now that the 6th edition has come. And it is very important to know so many of the things, the gray areas which were there earlier have been cleared, and so many things have been added for the semen analysis, the newer diagnostic tests, and the importance of the other interpretations and the tests. And now we have Dr. Rahul Reddy to highlight on all these dilemmas, how to clear it and how to interpret it, and what is new in the 6th edition that which can help us, all the infertility specialists, gynecologists, and all those who are handling the infertility cases, whether male or female. But ultimately we have to treat the couple, and it becomes very important to know about the male factor. And today we have with us Dr. G. Rahul Reddy, and it is my pleasure and privilege to introduce such a great andrologist. And he has got fellowship in andrology and men's health, and he is a consultant microsurgical andrologist, director, Androcare Andrology Institute, faculty in andrology, national and international conferences. He has got many awards: Best Junior Surgeon Award 2010-11, awarded by Apollo Group, Vaidya Ratna Award 2015 and 2017, Best Andrologist Award Worldwide Achievers Healthcare Awards 2015, Pratibha Puraskar 2016, and Andrologist of the Year Z Healthcare Award 2016, Best Andrologist Twin States 2017 by Times of India, and Best Andrologist again in 2018 by Times of India, Best Andrologist 2019 and Economic Times. And it is such a pleasure to have such a accomplished doctor and an expert in this field. And over to Dr. Rahul Reddy for his talk and to enlighten us on what is new in the 6th edition. Thank you very much.
Madam, thank you very much for your kind introduction. You are like my teacher, madam. It's an honor for me to get introduced by my teacher.
It is our pleasure also. See, that knowledge has no age. There is no age bar for knowledge, whether young or old. So that every day we will be learning. Thank you.
Thank you. Good evening, doctors. At the outset, I would like to thank Corona Remedies for giving me this opportunity and arranging this webinar. So today's topic is what's new in WHO manual, 6th edition of WHO manual. This lecture is based on a critical review and SWOT analysis by a group of doctors on a WHO manual. This group includes one of my teacher, Dr. Rupin Shah, and my beloved guide, Dr. Ashok Agarwal. So coming to semen analysis, we know that this is the first basic test we do when we see a couple with infertility. So it is a basic test for evaluating male fertility potential, and as it plays an essential role in driving the future management and treatment of infertility in couples. That means, whenever we see a couple older days, we just used to start the evaluation of females, and most of the males, they never used to come forward for semen analysis. And most of us used to think the problem is from the female side, and from male side problems are very rare. But nowadays it's not so. Most of the people now, if you see a study which is done on infertility couples who are undergoing ART procedure, more than 50% of the males, they have one of the other issues, and most of these patients, they have abnormal morphology. If you go through a series of semen analysis reports which are done in fertility centers, where a couple is undergoing IVF procedure, none of the semen analysis report is perfectly on the normal side. Very rarely you see that kind of report. In my experience, 70% of the males have some problem, and most common problem is morphology. So now, why these guidelines are there? Now WHO, now we are discussing about 6th guideline. Now why WHO started guidelines? It's a simple thing. Now we know as practitioners in ART field or practitioners in fertility field, we know when we see semen analysis reports, every semen analysis report is a different, and the format of semen analysis differs from center to center, and each the reference values from center to center, they are different. Some center says 15 millions is enough, some center says 60 to 120 millions is normal reference value, some center says morphology is as 80%, but same patient, if he undergoes semen analysis in a fertility center, you see morphology as 3% or 2%. There is gross variation in these reports. Why these variations? Because our centers, diagnostic centers, are not properly trained to do a proper semen analysis. Most of the times, this is done by a lab technician. We don't know the expertise of lab technician, and most of the people, they don't know where to get trained for semen analysis reporting also, because whatever they get trained during their lab technician course, they follow that guideline, and they start issuing reports. That is where the problem starts. So since at least somebody should come forward and start training these people. So now WHO has come forward to make sure that semen analysis is done in a proper manner, and it started its first guideline in 1980. Now it is sixth guideline, but most of the diagnostic centers still they follow fourth guideline or third guideline. That means whatever they learn during their training days, they follow that, which is a bad situation in most of the diagnostic centers in the world. I'm not saying this is the situation in India, but all over the world, most of the diagnostic centers they don't follow guidelines because they don't know that guidelines exist for this purpose. So now, are we really following guidelines? I think more, except fertility centers, most of the diagnostic centers, they are not following any guideline. So whatever we see in the report, we are believing that it's normal. Sometimes we see a male patient. For example, I have seen a male patient today. He has got almost 12 to 13 semen analysis reports since 2015, and most of the reports are normal. And first semen analysis, which is done in a fertility center, is totally abnormal and contrasting report, and they have referred this patient to me. Probably this abnormal report is existing since so many years, but this poor patient, because of the normal report from a diagnostic center, the couple has been roaming around the hospitals, and they have been roaming around the temples, hospitals. But they're thinking that semen analysis is normal and female factor is normal, then why they're not getting pregnancy? So now that is the need for us to standardize these diagnostic centers. Now, at least most of the fertility centers, they have qualified technicians who are trained to do a semen analysis sample according to WHO guideline. Now, if most of these guidelines, coming to third point, can we change the standard of semen analysis test? Yes, we can. So now, whichever diagnostic center you are depending, if you are working in a tier 1 city or tier 2 city, and if there is a fertility center close to you, you can ask your patients to get semen analysis from fertility centers. Or if you are depending on a diagnostic center for semen analysis, you can ask the technician to get trained in a proper fertility center for a week, so that at least he will know the proper guidelines and he starts giving a report according to WHO guideline. So it's we have to take the initiative. We just have to talk to the diagnostic center manager, or so that they can coordinate things. And when it comes to semen analysis reporting, where to send, diagnostic center or fertility center or andrology center, if you know that your lab technician who is working in your diagnostic center, if he is properly trained, okay, you can get it done there. Or else you can take help of local fertility centers for semen analysis reporting. Or else if you have your own clinic or hospital, you can send your technician to a fertility center for andrology technician training. It won't take more than a week. They can learn about semen analysis, they can learn about strict morphology, and they can also learn about IUI processing, which will be helpful for you. So apart from guidelines, we have to, how many of us we really bother about sample collection problems? Because most of the males, either they can't masturbate. Some people, they can masturbate in house, but they can't masturbate in clinic. Some people, they can only ejaculate with intercourse. Some people, they ejaculate only with masturbation, but they can't ejaculate with intercourse. These kind of problems has to be treated, because just asking for a semen analysis sample is alone may not help, because we have to find out whether he can give a sample or not, proper sample or not. And and at least one of the receptionist or lab technician or front office in our reception lab reception, they should explain the patient how the sample should be collected. That is very important, because how many days gap is mandatory, and when to give a sample, if they are collecting sample from home, how to collect, at what temperature they have to transfer the sample, in how many minutes they have to reach the sample. All these are very important, because the semen sample is highly sensitive. If it is exposed to sunlight, or if it is exposed to air conditioner, probably the motility will be on the lower side. Then we are reading a wrong semen analysis sample. So coming to WHO manual, we know that first WHO manual was published in 1980, and after that 5 editions have been subsequently released over last 4 decades. And in 2021, that means after 10 years of fifth manual, 11 years of fifth manual, 6th edition has was released. So before coming to 2021 guidelines, most of us, we are not aware of WHO 2010 guidelines. Couple of slides will discuss about that. It was 5th edition, and the reference range is derived from, because there is drastic difference between 4th edition and 5th edition. And if you compare with 5th edition and 6th edition, most of the changes are minimal. In 6th edition, apart from parameters, reference parameters, they have described a lot about the way of testing is done, and they mentioned about the procedure for advanced sperm test like SDF, ROS estimation. So now there is not much of difference between 2010 guideline and 2021 guidelines in parameters wise. So anyway, I will be discussing about that. So the reference range is derived from, so now you must be thinking how WHO comes to a conclusion of these reference values. It is derived from 4,500 semen analysis sample characterizing semen quality of fertile men whose partner had a time to pregnancy of 12 months or less. So raw data on from recent fathers in 14 countries and 4 continents, Chinese data with 429 semen analysis samples and 4 Singaporean semen analysis were included. But in 2010 guidelines, none of the Indian samples and other Asian nationalities and African nationalities were not included. The 5th percentile is given as the lower reference range for semen analysis samples, and no high value reference range is given as it is not considered detrimental to fertility. That means, so the old 4th manual, we used to think minimum semen analysis should be around 40 to 60 million. Now here in 2010, they have brought it down to 15 million. But it has given, there were so many confusions. So now what happens, what the patient, where we used to treat him for infertility in 4th guideline, and now he has become totally normal according to 2010 guidelines, because the patient with 25 millions, we used to think that it was oligospermia. Now according to 2010 guidelines, he was absolutely normal if other parameters are normal. So that was the confusion for us. But again, there were criticisms saying that this data was not from all over the world. Only they have selected from the couple of countries. They didn't include African, South American, Indian, and other Asian countries and Australia. So if you see the reference values, they have changed over the time from 1980 to 2010 guidelines. So now if you see total sperm count, in 80 it was 20 to 200, in 87 it was more than 20, then gradually it is decreasing. Now in 2010 guidelines, 15 millions is considered to be normal lower reference value. But coming to motility, In 1980, we used to consider minimum of 80% motility should be there. Later it has come to 40% in 2010. Whereas morphology in 1980 it was 80%, which is the normal range. Then it came down to 50, then 30, then 40, and finally in 2010 it came down to 4. But the way we do morphology has changed. Previous days we used to just it's a visual morphology. Now it is called it is strict morphology. That means each and every sperm has to be individually seen under high power microscopy, and then we have to come to a proper count. So over the years there are so many changes. Now if you see the percentile values, what WHO says it is normal is only 5th percentile. That means the people below this those patients who has semen parameters below this 5th percentile values are considered to be infertile, and if they are above this 5th percentile value, then WHO says it is normal. Again, this has led to a lot of confusion. So now most of the patients, when they ask us, doctor, if it is more than 15 million, am I totally fertile? Then we don't have an answer. Ideally, what has to be done is our template for semen analysis should be like this. Now we have to tell patient that see your semen parameter according to 5th percentile is normal, but most of the patients in 50th percentile we have to compare it to 50th percentile and 95th percentile. Then we have to explain. Otherwise, it's very difficult for us to answer their questions. They say, doctor, my semen parameter is normal. Why still I'm not getting pregnancy? But then at least then we have a point here. If you compare with 50th percentile, we have to tell them that still, if you compare with, you are just above the 5th percentile, but it is totally not normal. You may get pregnancy with this, but chances are not as compared to 50th percentile. So now that is why I request all the doctors to follow this template, which is according to 2010, but I think I'll prepare a template according to 2021. Then explanation, explaining the patient and the couple easy for us. So coming to 6th edition, what's new? We all know that semen analysis is a cornerstone for male infertility evaluation, and 6th edition has made the analysis of basic semen parameters more robust, taking into the account the criticisms and gray areas of previous editions. SWOT analysis summarizes the changes and novelties compared to previous editions. The main novelty is that this latest edition abandons the notion of reference thresholds, suggesting instead to replace them with decision limits. But problem is, no decision limits are proposed for either basic semen parameters or for extended or advanced semen parameters. Again, we are in confusion. So this new edition commended the importance of semen analysis as a tool to assist fertility or infertility diagnosis, to assess male reproductive health and function, to guide the management, and to guide the choice of ART procedure. That means based on his semen parameters, we can guide the choice of ART procedure, that is whether they are to go for IUI or IVF or HC, if it is with IUI, whether it's a plain IUI or with the help of MAX or microfluidics. At least we can guide the choice of ART procedure, and it also helps to monitor the response to the treatment. That means if a patient is on medication, at least when we do next semen analysis, then we know whether this patient is responding or not. And it also helps him to measure the efficacy of the male contraception. That means after the surgery, after the vasectomy surgery, what whether the semen parameters have declined or not, they have started declining or they have come to zero, or it is in still severe oligospermia. So that is important, because after vasectomy procedure, we should be in a position to tell whether the surgery is successful or not. So the sixth edition aim to optimize semen analysis procedures by including detailed steps and a methodological sequence for the test execution. So they have given a detailed step-by-step procedure, how a semen analysis sample should be done, how it should be diluted, and how to measure the concentration, how to measure motility. All these things they have explained in a detailed step-by-step way. The newly established manual also described new sperm tests for the assessment of SDF and seminal oxidative stress, while abandoning the absolute test like human cervical mucus examination. The sixth edition contains results of semen samples of 3,589 fertile men. Out of them, 1,800 samples were from fifth edition and 1,789 samples from new subjects. So the major changes in the objectives and methods from 5th to 6th edition are given in this slide. I'm not going into detail about objectives and methods. What is important for us is what has changed. So coming to basic examination of semen, the new point which has been added is evaluation of semen odor. This was not there in 2005th edition. Evaluation of semen odor is added in this edition, and they have readapted the distinction of progressive motility into two categories, like grade A and grade B. Actually, this was there in 4th edition. So according to 4th edition, we used to say whether it is rapid progressive or slow progressive. We used to have a semen analysis sample which used to say A plus B should be more than 50, A should be more than 25, B should be more than 25. Now, to avoid confusion, they have taken out in 5th edition. They said in 5th edition, there are only 3 parameters: progressive, non-progressive, and immotile sperms. So there, according to 5th edition, motility should be more than 32%, according to 5th percentage. But now they have readopted this, and now they say again you have to give rapid progressive sample concentration and slow progressive concentration. This is based on the test that rapid progressive sperm percentage has a role in natural conception. So now that is the reason they have brought back fast progressive or rapid progressive motile sperm percentage. The evaluation of sperm count and semen dilutions have been simplified now, and the assessment of sperm vitality is recommended when total sperm motility is below 40%. Sperm morphology assessment using systematic approach is described with multiple and better quality monographs compared to 5th edition. So apart from basic examination, coming to extended examination of semen, different methods of SDF testing, including tunnel assays, sperm chromatin dispersion assay, comet assay, and acridine orange flow cytometry assay have been discussed. And they, because this is difficult thing, because if you are into fertility practice and if you get sperm DNA fragmentation report from different laboratories, and the way they are testing is again totally different, you get confused. One lab says DNA fragmentation as 50%, second lab says as 11%, because again, as how you used to see semen analysis, same thing is happening with DNA fragmentation testing, because sometimes we are using flow cytometers, some centers are using SDF test kits, SCD kits. So there is no standardization. Now WHO wants standardization even in extended examination of semen. That is why they have included, they have explained about SDF testing. And detailed outline on the technical aspects of the test, and some guidance on the interpretation of the test results is given, and awareness on genetic related infertility, and especially on sperm chromosomal abnormalities and gene mutations was explained, and sperm genetic tests and how they relate to male reproductive biology and associated fertility disorders have been explained. So now we know, at least according to guideline, when to ask for a genetic test and which genetic test has to be asked. So now most of us are in confusion. Some laboratories, even for azoospermic sample, they ask for karyotyping, Y chromosome deletion, and CFTR gene mutations. So now CFTR gene mutation is only in patients with bilateral congenital absence of RAS difference, not for other patients. So coming to advanced examination of semen, the evaluation of oxidative stress, sperm acrosome reaction, functional analysis of transmembrane ion influx, flux and transport in sperm are methods for the evaluation of chromatin condensation. All these have been explained in new manual. Seminal oxidative stress is described with ROS under advanced examination of semen, because ROS testing nowadays we have test kits for ROS. We have both two ways of doing ROS, and this ROS estimation will tell us whether the medication what we are giving is helping or not, because most of the times we depend on antioxidants for treating male infertility patients, but whether what is their ROS level, because our treatment should be guided based on their ROS level, because sometimes if you over treat them, even ROS levels, if they subside totally, then that is detrimental for the patient. In spite of giving antioxidant, most of these patients will not improve because ROS is totally suppressed. So coming to sperm preparation and cryopreservation, again, this manual has mentioned about novelties of this, mentioned about description of magnetic activated cell sorting technique and sperm vitrification technique. So this was in talk since last couple of years. Now most of the patients with high DNA fragmentation are patients with significant pyospermia or persistent pyospermia. We started using this MAX technique to select better quality sperm for ART procedure. Now our results are compared to previously. Whenever we see a patient with high DNA fragmentation, we used to suggest testicular sperm for ART procedure. At least now 50% of the patients, now we don't have to do that. At least patients in borderline sperm DNA fragmentation, high DNA fragmentation, we don't have to do testicular sperm retrieval for most of the patients. Now MAX procedure or microfluidics will help these patients in avoiding a procedure or testicular sperm aspiration. So coming to thresholds of basic semen parameters, I think this is the important slide what everybody is waiting for. So what is the difference between 5th edition and 6th edition in lower 5th percentile parameters? See, if you see semen value in 2005th edition, it was 1.5 ml. In 6th edition, it is 1.4, and average is between 1.3 to 1.5. Coming to total sperm number in millions per ejaculate, it is same in both the guidelines. Coming to concentration, now concentration is 15 millions per ml in 5th edition and 16 millions per ml in 6th edition. Coming to total motility, it was same. It's almost same. It was 40 into the 5th edition and 42 in 6th edition. But progressive motility has come down. They say according to 5th edition, it was 32% is lower reference value. In 6th edition, it is 30%. So now even for non-progressive motility and immotile sperms, they have given percentage, but we don't have to concentrate on these things. Now vitality is again important. Whenever now this manual says if total motility is more than 40%, then we have to do vitality in these patients. And coming to morphology, there is no major change in morphology because both the guidelines they stick to strict morphology or Kruger's criteria. So now coming to this SWOT analysis, this is called strength, weakness, opportunity, and threats analysis. So according to this analysis, let us see what are the strengths, weaknesses, and opportunities and threats of this WHO manual for 6th edition of manual. Coming to strengths, the extensive data on human semen in 6th edition provides important insights into global management of male infertility. That means at least we know what has to be done in patients with this set of parameters and what happens. That means previously we used to think if semen analysis is count concentration is less than 10 millions, we used to ask them to go for IVF ART procedure. If it is between 10 to 15 millions, we used to ask them to go for IUI procedure. If it is more than 15, we used to ask them to go for we have to try naturally. Now, this extensive data will tell us what has to be planned and how many of them succeeded. And coming to second point, it addresses the criticism of imbalanced geographical representation in the previous 5th edition by adding new data of fertile men from Southern Europe and Asian countries and Africa and including Indian samples. It provides an updated laboratory technical guide on semen analysis that includes comprehensive step-by-step procedures. It provides detailed information on quality control and quality assurances that can help guide optimum laboratory performance. And it introduces SDF and FISH as extended tests of semen that can be recommended in certain clinical indications. It acknowledges that 5th percentile values of basic semen parameters alone are sufficient for accurate diagnosis of male infertility. So coming to weaknesses, the data on fertile men from some geographical areas such as South America and Sub-Saharan Africa are still underrepresented. It lacks reference thresholds or decision intervals to replace the 5th percentile of basic semen parameters. It also lacks indication and criteria for interpretation of SGF testing. And it lacks cutoff or threshold values for extended semen analysis such as SGF test. It considers seminal oxidative stress tests as specialized, mainly research-based procedures despite extensive literature data suggesting their clinical use and implications. This is true because most of the fertility centers, they started doing ROS testing since the last 5-6 years. Now WHO still considers that this is a research-based. Coming to opportunities from this 6th edition, future research may help determine globally accepted reference ranges and thresholds that would be useful in the management of infertility. Future research may help in the development of updated guidelines on advanced sperm tests such as sperm fragmentation and FISH. Future research may help incorporate epigenetic and seminal oxidative stress testing into clinical practice. Coming to threats of 6th edition, the abundance of technical details in the manual may diminish interest among the clinicians in reading and adopting it. This is very important point because if it is simple, most of the doctors they read it and follow it. as as it gets complicated, most of the doctors, they stop reading it, they stop following it, they start I think this is the important thing, because most of the doctors, they are not interested in all these parameters. They want only the normal reference values. They stick on to that, and they don't go deep into the sixth edition manual. So they have to make it simplified, and the lack of reference values for basic and extended semen parameters in the edition may preclude the global utility of this manual, and instead increase the chances for continued use of fifth edition reference values. So, to summarize, the new sixth edition presents revised reference values of semen parameters based on the combined data of fertility from previous fifth edition and 5 additional studies published between 2010 and 2020, thereby attempting to address a limitation noted in the fifth edition. In addition, the advances in the laboratory techniques of semen examination were discussed elaborately, and the sixth edition also highlights the recent developments of techniques of sperm preparation, cryopreservation, and recommends that the laboratories adhere to optimum quality control and quality assurance measures, and provides important insights into the global management of male infertility. Thank you, doctors. I think it's a boring lecture, but the final point what you have to take is, now there is not much of difference between fifth edition and sixth edition in your clinical practice point of view, because the reference values are almost same, except the reference value in motility, where they have brought back rapid progressive motility into the reporting. So apart from that, if you can go through about the importance given by WHO manual for DNA fragmentation test and sperm oxidative stress measurement, because they are very important in assessing the couples who are undergoing ART procedure, because this will change the result of their ART procedure. Thank you, doctors.
Thank you very much, Dr. Rahul Reddy, for that lucid presentation. Though it is not certainly not boring, at least we must know what is happening, what are the standardization that is available. The most important thing which you said is that each person, when they come for infertility, we always, it's everyone's experience that we see bundles and bundles of reports. Sometimes almost every month he will have got it done. And so many will not mention everything, simply 1, 3, 4 items they mention and leave it. So we don't know which laboratory is really doing a proper work and which is not doing that, and how to say that this report. So many times they bring report that 60 to 70 million sperm count. When you get it done here, it will be azoospermia. So I don't know what they're counting and how they're doing that. And as you said, it is very important for the standardization and uniformity in all the laboratories, so that every gynecologist can interpret it in a proper way. And ultimately, it is the patient who will be benefited. So because we base our diagnosis, treatment, or other extended tests, depending on the report, what we get. So that is in smaller places and small laboratories, and most of the time we are not getting proper report. So that is why actually creating awareness, training them, and that becomes very important even in the smaller laboratories when they do it. So that is what I say. All these extended tests, what else tests normally you advise in this, what they have described?
Two things, yes, madam. One is ROS estimation, and second is DNA fragmentation.
Yes.
The main role of DNA fragmentation comes before ART procedure, madam. And commonly we see couples with repeated recurrent early pregnancy loss. We never give importance to semen parameters. Most of the times we think that semen analysis is normal, and the man is nowhere related to this early pregnancy loss.
Yes.
This is the situation where we have to do DNA fragmentation.
Okay. So bad obstetric history and recurrent abortions and all these things. That is one of the, though it outwardly it looks like a normal semen report, I think we have to go to the depth of it.
Yes.
So in the genetic testing, are you doing it routinely, and how common it is and how costly it is?
Though my center is andrology center, I don't generally ask for genetic test because doing a genetic test is very expensive. Only people who are planning, who are affordable for ART procedure, I ask them to go to a fertility center, and most of the fertility centers, they do genetic tests before before planning for ART procedure. Because routinely doing it for every patient may not help, because in India they are very expensive. All the Y chromosome microdeletions is around 8 to 10,000 rupees, and the karyotyping is around 3 to 4,000 rupees. Generally, I don't recommend for everybody, unless if patient is affordable, he wants to know the cost, then I do it in myself.
Sometimes I have seen when the family, the brothers, 2-3 brothers, all infertile.
Okay.
So the semen parameters, some little subnormal semen reports we are getting. But you can say my brother hasn't got the child, my another brother also hasn't got the child. In such situations, what all investigations you commonly do? But because the whole family, whole brothers, they haven't had the child. For that.
Y chromosome microdeletions and the karyotyping.
Exactly.
But most of the times, even Y chromosome microdeletions, we are not checking for all the variants. Most of the labs, they restrict themselves to certain variants, because giving an elaborate report will help us. But in spite of spending so much money, but if you still get a normal report and with few variants tested, then it won't help us.
Yeah, in this Y chromosome deletion, microdeletion. So how do you counsel them, and what is your?
No, in only scenario, madam, where they are planning for testicular sperm aspiration or any surgical procedure. Before doing that, this will help us whether there is chance of getting a sperm or not. We can guess, but in my experience, if they are not giving all the parameters, because most of the labs they are not because recently I have seen one patient. The test which was done in Bangalore says there is Y chromosome microdeletion, AZFC deletions there. But same test repeated in Hyderabad says it is normal. So now again, patient is under confusion. He says, "Doctor, sir, what should I do? Whether I should undergo a testicular biopsy or a TISA procedure or not?" So in spite of spending 28,000 rupees or 30,000 rupees, so nowadays what I tell them is, if only for diagnosis purpose, you get a test done. Otherwise, doing a testicular sperm aspiration is easier, less expensive than doing a genetic test.
It's true.
For countries where insurance covers all those tests, so ideally they can go ahead with all those genetic tests because they are not paying from their pocket.
Yeah. For us here, certainly the cost is a major factor for majority. Only a small percentage of patients may be affordable. So, but if it is available and if they can afford to do it, certainly they can go in for that. And
in Hyderabad, there is an institute. There is Institute of Genetics. It's a central government institute. Generally, I refer patients there. Sometimes they do some tests free of cost. I don't know why they charge for some patients, but their charges are minimal. Cost compared to other centers slightly on the lower side, and they give free genetic counseling.
Do you know such center in Bangalore also?
No, I don't know. I have to find out. Okay. Even I came to know about this.
Yes. So we can make use of it.
Pus cells. Do you treat pus cells, and you find microscopy pus cells?
Yes.
When do you treat?
No,
as per the 6th edition.
Yes. See, madam, generally, only treating pus cells should not be done, madam. You have to go for a semen culture test. If there is persistent pyospermia, sometimes laboratories they confuse between round cells and pus cells. So now if it is done in a fertility center, if they are saying pus cells are there, then the end stage, they must have done end stage, and at least you can confirm that it's a pus cell. Then you can start treatment. In general, if it is done in a diagnostic center, easiest way for you to find out whether it is really an infection or not, just do a semen culture test. Semen culture is positive with an organism like E. coli, Klebsiella, or Enterococcus faecalis. Then it's a genuine infection. Then you can give antibiotics. If pus cell is from urethra or urinary bladder, then you don't have to treat them unless they have symptoms.
Okay.
Most of the time, the semen culture, when we send it, it comes as negative only. Very rarely we have got semen culture positive.
No, for us, almost we do at least 20 cultures a day.
Yeah.
70 to 80% will be positive.
Oh,
In
Okay,
my
that means to
experience,
say the what Pyospermia or the pus cells they have given may not be pus cells. It may
Yes.
not be infection. That's why it comes as sterile. What antibiotics usually you prefer in such kind of treating infection in semen?
according to our study, this study what we did in our center, the commonest bacteria what we identified is Enterococcus faecalis, Klebsiella, and E. coli. So for Enterococcus faecalis, ampicillin 500 milligrams twice daily for 2 weeks helps very well. Most of the times it works. If it is not working or if it is resistant, generally I give them linezolid, 600 milligrams BD for 2 weeks. If it is Klebsiella or E. coli, generally I give ciprofloxacin or levofloxacin. But if pus cells are there and semen culture is negative, generally then I give doxycycline, because in India, chlamydia, STDs are very common. Infections like chlamydia, they don't come in semen culture. So STD related infections, doxycycline works.
So that's the commonest which is used, and the ofloxacin I'll also seen many people using that.
Same group.
The doxycycline has developed resistance. They have developed resistance to doxycycline because very commonly it is
very
used.
No, you have to give it for at least 3 weeks. Doxycycline, there is no point in giving for 1 week or 2 weeks. Minimum 15 to 20 days is ideal period for doxycycline.
For reduced motility, what treatment usually? Other antioxidants and other things, are you using it regularly? Because we have so many from so many different.
Madam, motility, there are only 3 things which can lower motility. One is hormonal imbalance. Second one is increased testicular temperature, either because of varicocele or because of obesity. And third one is epididymal inflammation. Any infection in the epididymis or seminal vesicle can cause decreased fertility. So these 3 things, if it is hormonal imbalance, then you have to correct the hormones. And in obese people, most of the time there is abnormal TE ratio. Abnormal TE ratio can decrease motility. Testosterone to estrogen ratio. And if it is infection, just treat their infection and give long-term anti-inflammatory medications like Thimerol 4 along with antibiotics, and give antioxidants. Only giving antioxidants may not help these patients. If it is heat, then we have to ask them to do something. If it is because of tight undergarments, we have to ask them to cool their testes. If it is because of varicocele, then we have to ask them to go for surgery.
Thank you.
What about the fructose? No, is it of any value?
No, only in obstructive azoospermia, that too at the level of ejaculatory duct, fructose is important. Otherwise, in general cases, there is no use for fructose.
Okay. Thank you. So, like in many labs, they don't have the in-house person who is capable of doing semen analysis immediately.
Yes.
So they depend on the pathologist coming somewhere in the evening. and doing it. So what is your opinion about that?
No, that is where all the mistakes are happening, madam. That is
Mhm.
why we have to standardize those laboratories, because most of the times these lab technicians, if what we have seen is some centers, if senior lab technician is there during the time, you get correct report. If junior lab technician is there, you get wrong report. What we have noted is these junior technicians, since they don't say that they don't accept that they don't know semen analysis, sometimes they just copy the previous semen analysis report and then give a report. This is commonly happening in most of the diagnostic centers.
For counting, do you use that new bar, that old?
McLear's is easier. McLear's, though it is expensive chamber, it may cost you a little more, but it's easy to count.
Okay.
You don't need any technician. Even if you have a microscope, simple microscope with the 20x magnification and McLear's chamber, for count, you can directly see it on your microscope.
Okay.
The computerized semen analysis, so much they give the advertisement about that. What is your
Now, madam, I have two computerized semen analysis reports lying in my center, but now I just use them as recording devices. Madam, what happens is, all these CASA machines, they overestimate the count. They calculate all the moving particles because it's only imaging technique. Whatever is moving, even round cells, first cells, whatever is moving, they count them as sperm. So I think technology should improve, and if you see a semen analysis sample which is done manually and with CASA, always counts are on the higher side in CASA machines.
So probably the take-home message is it should be done in a place where there is a lot of turnover and the person is there appropriately trained, not to do in small places, because there are lots of errors, mistakes, and anxieties for the patients.
No, simple thing, madam. Now, if you have your, it's always better to have your own semen analysis lab, because the cost of equipment is not very high, madam. Only what you need is only one McLear's chamber and one pipette and one microscope. So if you have a technician, you can send them to any fertility center for a week training, 1 week training. Most of the fertility centers, they are giving 1 week training in semen analysis. They can learn and they can come back. And so if there is one person in your center, then he can train other people also.
Okay.
What is the duration of abstinence you usually advise?
3 to 7 days. 48 hours to 7 days.
7 days, isn't it quite a long time, no?
Or for dead sperms, you get.
Then for dead sperms, it's always better to give after 48 hours.
Yeah.
No, if patient is far away from faraway place, if he says, doctor, I have traveled long distance for this semen analysis sample, generally then we accept till 7 days. If it is more than 7 days, then better not to accept. Ideally, it is 48 hours.
Okay, thank you.
Any other thing, any other advice to gynecologists you want to give? In your experience, what we are expected to do or what we are supposed to do?
It's simple, madam. Most of the urologists are not interested in fertility treatment, except evaluation of varicocele and doing surgery, because it needs some time. Because we don't, as a urologist, for us giving lot of time explaining all those the questions, it is difficult. So now 80% of the infertile couples are seen by gynecologists. So it's better, instead of referring, if you see your own patient and treat them, it's always better.
When do you advise varicocele surgery commonly?
3 months of antioxidants, and at least if it is in IUI range, I ask them to go for IUI. If they are not willing for IUI, and coming to grade, man, this is very important question what you asked. Only if it is clinically palpable varicocele or bilateral grade 2 or at least unilateral grade 3 varicocele, then only it has to be operated. Just ultrasound recorded grade 1 varicocele or non-palpable varicoceles, generally there is no point in doing surgeries. It should be either bilateral grade 2 or at least unilateral grade 3 varicose.
And semen analysis report.
Semen analysis report. And generally I do hormone analysis for all these patients. If FSH is very high, that means if patient is already in testicular failure where FSH is more than 15, 20, with small atrophic testes, there is no point in doing varicocele surgery unless they are willing for ART procedure. Already one IVF they tried and embryo quality is very poor, and only if they want a better quality sperm for the next IVF procedure, in those cases we can attempt varicocele surgery. Otherwise, with high FSH, small testicular size, the improvement after varicocele surgery will be very minimal. So selection of patient is very important.
The semen analysis is normal, and what the report they give grade 1 and grade 2, so there is no need to do it.
No need to do. Even for grade 3, madam, sometimes we see patients, they come with normal semen analysis report and with a scrotal Doppler report saying grade 3 varicocele.
Yes.
So there, one DFI test will help us. There you can ask for DFI test. If DFI is on the higher side, then we can do varicocele surgery. Otherwise, if semen parameters are normal and DFI is normal, we don't have to do surgery for all.
Thank you. Any other questions from the delegates?
It was good. Thank you.
Yeah.
Thank you.
Very useful.
All
All our postgraduates are here logged in.
Nice.
Thank you so much for logging in, and sir and ma'am, thank you so much for joining us.
Dr. Uma Devi, who is treasurer of Bangalore Society of Obstetric Gynecology, very knowledgeable person with us.
That's great, ma'am.
Yes.
Yeah.
Hello, ma'am.
Actually, thank you. Actually, the semen analysis 6th edition, no, they should know thoroughly what is the change, because it can come for the national board exams also.
Yes.
What changes? Critically evaluate also, they can have a question.
For exam
So
point of view, very important to know.
Yes.
That by treatment point of view or not.
Treatment also, I think now puzzles is a change, no? That's not to treat. Otherwise, routinely we used to treat all. If any puzzles is there, treat.
Yes.
That is true.
Now I think with the culture only we should treat. Without culture, no need. Any cutoff is there?
No, it's
Beyond 2 to 3.
No, bacteriospermia and pyospermia both are different.
No, puzzles, just routine examination of puzzles. When do you do the culture?
More than 5 to 6, madam. Culture,
5 to 6.
Culture, generally you get a bacteria, madam. Bacterial count.
Bacteria present. Okay.
Yeah. And they will give us bacterial, what bacteria is there and what antibiotic is sensitive for that. We get that report in culture report.
Okay. Thank you.
This, thank you so much, ma'am. Thank you so much, sir, for joining us today and letting us.
For your coordinating things and the corona remedies.
Yeah, thank you.
Thank you very much, Dr. Rahul Reddy, for that enlightening session.
Thank you. Thank you.
Thank you so much, ma'am and sir, for joining us today. And there were a lot of viewers who have been joined us, and also we have 14 participants who have joined and heard about the update. So thank you. Be connected, and thank you so much.
Thank you.
Good night to you all.
Good night.
Good night.
Good night.